Everybody, and welcome to what is the last of our West Suffolk CCG boards. You will have noticed, I think, in your diaries that there is a short joint mop-up board on the 28th of June, which will be a wrap-up and handover board. But this is our last substantive West Suffolk CCG board. Joe, do we have any apologies?
The only apologies I've received are from Steve Chicken, and Amanda Lies is going to be arriving late.
Okay, thank you very much. Any declarations of interest, hospitality or gifts? Never any gifts these days, no. The minutes of the last meeting. Those who read the minutes, is everybody happy that they represent a correct record of that meeting?
Yes.
Thank you very much. Any matters arising? Thank you. And the action log, there's only one uncompleted action, isn't there, which is that it's a little bit out of date now because vaccination isn't in the front line anymore. But the principle of it, when somebody who has some disability, learning needs, or autism or whatever needed special support for a procedure, I think still holds. And so I think, although it is not sensible to leave the last board meeting with actions uncompleted, because there's nowhere for them to be reported, I do think that if possible, a little round robin to those in primary care as to where they might refer such people would be helpful. Thank you. A general update, Ed.
Thanks, Chair, and just wanted to also say what a pleasure it's been being part of this board from its creation to its closure. It's had a lot of very happy memories. I've always enjoyed meeting in the cathedral. It's a shame that this board couldn't have been face to face in the cathedral. Yeah. But it's been an absolutely brilliant board and organisation to be part of, and particularly Christopher, thank you to you, who's been our chair all the way through, and had a very steady and balanced approach, I think, to the CCG, and I think that's been of great benefit.
You say the nicest things. Thank you very much. While you're thanking, sorry to interrupt you, but could I just, because I might forget at the end, I just want to thank Joe, who's also been with us for that length of time, who suffered in silence for the whole of the 10 years, done wonderful minutes, and provided faultless support. So I'd like to get that in now in case I forget it at the end. Sorry to have interrupted you, Ed.
No, thank you for that.
Thanks, Christopher.
So in terms of the transition itself, we're confident that we'll be able to launch the new NHS Suffolk and North East Essex Integrated Care Board on the 1st of July. The process for completing the membership of that board is reaching its final stages, and for both in terms of partner members, but also in terms of the executive team. The one executive post we're out to advert for is the Director of Finance, and again, it's an opportunity to say thank you to Jane, who's been outstanding in her role, as I'm sure we'll all agree, through the past 5-6 years. It's just been absolutely brilliant and done it with such professionalism and good humour. So thank you, Jane. In terms of the key issues from the last 3 months, I think they'll be picked up. I know they'll be picked up on the agenda today, but the big 3 issues have been around elective waiting lists and the recovery of them, and it's very good to see that waiting times are coming down across the ICS, and the difference in waiting times between West Suffolk and the East Suffolk and North East Essex patches are equalising, in part due to mutual aid, but now that theatres are starting to reopen in Bury, that's extremely helpful. So making some strong progress on elective recovery. Urgent and emergency care system has been under significant pressure, and we did have a spell where we were on opal 4, which was the highest escalation level. But for the most part, we've avoided that, and we're now consistently on an Opal 2 level. And so we've been more resilient than many systems during the past few months, which is a great credit to everyone involved. We've had a particular focus on ambulance handover delays, and West Suffolk has comparatively performed well on that, despite the constraints they've got in their estate. So that's real testament to the teamwork that we've seen at the front door there. And then finally, people will be very aware that the CQC have given the Norfolk and Suffolk Foundation Trust another inadequate rating, inadequate around safe, effective and well led. The CQC have made very clear, as we all have, that we cannot tolerate inadequate services, and they're looking for significant improvements by the time they revisit sometime in the coming months. And that's a very clear message that the Trust and everyone has heard. So those will be my updates. They will be fleshed out in more detail during the agenda, Chair.
Thank you very much. Thank you. Any questions at this point for Ed? Okay, thank you. Right, so straight on then to the patient and public involvement Q4 activity report, Lisa.
Thank you, Chair. So yes, you've received the 4th quarterly report for the patient and public involvement team. It details the types of involvement and activity that we have around public and patient involvement across the alliances, all the programmes, and also our internal services around PALs and complaints. You'll see that the contacts from MPs has significantly decreased. I reported in the 3rd quarterly report that we had some significant MP contacts, and that was related to the vaccine programme. So that has resumed to normal levels of contact now. As we've talked previously with the strategy, we have an ambition to improve the evaluation and feedback loop when we co-produce with our public. So we do pretty well identifying areas where we need to improve services with public. We have some great examples of co-production, not consistently, but some good examples that we build on. But we know that patients and public feel that there is no closure to that loop for them around then measuring impact, measuring outcomes of service, and doing that whole PDSA cycle. We get stuck with our citizens on the P bit, really. So you'll see we've started to do some of that work. We've started with reviewing the effectiveness of the community mental health practitioners, and we're asking for support and feedback. And the other area that we are really increasing is through our digital engagement platform. So, we have our SNE Let's Talk platform, which we did a bit of a soft launch for because we anticipated that it could run away with us if we did a massive hard launch across Suffolk and North East Essex. But the numbers of surveys and engagement that we're doing through that digital platform is increasing all the time. The next stage for the team is really looking at developing the citizen involvement forum as part of the ICB. So that will be a formal subcommittee of the ICB board, and we're just really looking at the transition from CCG to ICB. Obviously, our providers will be part of it, as will a number of user forums. So that's the piece of work that's really ongoing at the moment, as well as developing our patient safety partners as part of the NHS patient safety framework. So happy to take any questions, but I won't go through the individual elements of the report. Thank you.
Thank you very much, Lisa. Are there any questions for Lisa? Okay, thank you. Move on then to item 8, the West Suffolk Alliance update. Sandy.
Thank you, Chair. This is sadly the last Alliance progress report to this meeting, and we'd really like, as outlined in the report, to give our heartfelt thanks to all of our members in with your valuable support and guidance throughout the establishment of the Alliance. I think the strength of our relationships and partnerships locally have been a testament to the way that our CCG governance has formed and progressed and engaged, and I think we've laid some very solid foundations for our transition now to the new arrangements. The maturity of the West Suffolk Alliance as part of the ICB will take some time, we know, but the governance has now been agreed, although of course will be subject to review, particularly in the first year. To note, both the Alliance Director and the Chair of the committee will have a place on the ICB, and that is an important connection with the ICB governance on our place level governance. The committee, we're pleased to say, will meet for the first time formally on the 12th of July with a focus on strengthening our process, and we'll have a deep dive into one of the key service areas. And we've elected to have a focus on mental health, and that's work in progress. There's one remaining gap. The expression of interest is likely to go out beginning of next week on the committee for a GP representative. We've been having conversations about that role, and expression of interest, as I say, will go out next week. The delivery group, the Alliance Delivery Group, has already met, and I've signed off the initial priorities for 22-23. Key within that will be the refresh of the West Suffolk Alliance strategy that's due to complete and end at the end of this calendar year. But we also want to use the time to review the governance, reset the governance, and ensure that we've got a collective approach to the key enablers, such as workforce engagement and digital. Key within those priorities are obviously the elements that come out for the national planning framework, which we're all familiar with, but also some of the work that we've agreed as an alliance in 21-22. We're keen that we absolutely start to progress and mature the integrated neighbour teams, start to have a focus on developing our community assets with a strengthened approach to social prescribing, and to embed our digital technology within all service areas, building on some of the work that we've already commenced. And a mention to Andrew's work around leading the end-of-life Rosie app. We've absolutely committed to ensure that that's rolled out and implemented across the board in 22-23. The West Suffolk Alliance operational group met in its new form yesterday, very well attended, having a focus very much on our urgent and emergency care strategy and its alignment with the other work streams. And we have now developed and co-created a system plan around how we take that forward. And that will feed not only into the delivery group, but the SNE UEC forum. Finally, as we transition as part of our ICB, we're committed to build on all the great work that we've progressed over the years. I think we've in a strong place to progress our priorities. We're committed to ensuring that the engagement that we have with our system partners, including our members here today, continues. And once again, I thank you all very much for your contribution.
Thank you. Any questions for Sandy? Okay, well, thank you very much. That's very well received, Sandy. So now we go to item 9, which is the research strategy for the Suffolk and North East Essex Integrated Care System. Lisa.
Thank you. And I, without further ado, I'm going to hand straight over to Claire Sims, who has been amazing at bringing us all together and facilitating workshops to develop the research strategy. So Claire will present it. Thank you.
Thanks, Lisa. So just by way of introduction, I'm Claire Sims. I'm the Head of Research Management, Finance and Patient Public Involvement at Norfolk and Waveney CCG. But we have an SLA with the Suffolk CCGs to support your research activity within the CCG and across sort of primary care. And we work very closely with the local clinical research network in the east of England. And as Lisa said, we've developed the strategy following a series of 2 workshops that we held at the end of last year, looking at what the current research picture was across the ICS and also where we wanted to be as a system, recognising that obviously we're going to move into an ICS as of July. And this was quite well attended and there was a lot of enthusiasm at the workshop, and we had members from our trusts, the CCG, CCGs, academic partners, primary care and some patient and public representations, including members of Healthwatch. So the strategy has been sort of built on the back of those workshops. And just to give you a bit of context, as you may or may not be aware, the CCG currently has a duty to promote research, and this duty is being translated across the ICB. And it's also been sort of strengthened slightly in that the ICB will have a duty to promote research innovation and the use of evidence, but is also expected to support partners within the ICB to do the same, really. CQC use research activity as a marker of a well-led organisation, and a lot of the evidence is now fairly well established that hospitals in particular that are research active have much better outcomes for their patients, and that's across all services, not just those directly involved in research. And the evidence is growing that this applies to other settings as well. And obviously, we've learned a lot from COVID and from the COVID pandemic, and there was a huge contribution that research made into advancing our knowledge of COVID, effective treatments, developing the vaccinations, and there's quite a lot of evidence about the number of sort of the direct impact on patients through the research that was done, and a huge number of patients across the whole of the country, and including the sort of Suffolk and North East Essex area, were involved in a lot of those trials through the hospitals and through general practices. And over the last few years, there's been quite a lot of engagement in research, and you know, even sort of post-pandemic, the numbers of engaged in research is still quite high. And across the Eastern region, we had over 90,000 individuals involved in research over the last year, which is about 2% of the population. And within the Suffolk and North East Essex area, that was over 10,000. So the strategy really was developed to build on the work that's already been happening in the region, and sort of to take forward the sort of ambition for research over the next 5 years. It was developed to be quite flexible, because obviously we're moving into an ICS, and it's recognise that things are changing, the environment's changing. So the strategy was developed to really try and be quite flexible, to adapt to some of the changes that are happening. I'm aware that your sort of higher ambitions are being reviewed and looked at, so hopefully the strategy can work with any changes as we move forward. And I think what came out quite strongly from the workshops was that there was a real drive and enthusiasm for research, and a drive to work in a very collaborative way, in line with the sort of move to an ICS, and to also to ensure that the research that was undertaken in the region is both meaningful and accessible. And I know there's a lot of work being done so nationally and regionally in terms of making research as accessible to the population as possible, because it is recognised that some of the groups that research has the potential to benefit the most are probably the ones that are least engaged. So there is a lot of work going on in that arena, both with the research network locally and nationally. And we've also built in a number of outcomes into the strategy, really to look at what are we trying to achieve through this strategy, and how might these be measured. So sort of building our research profile and our reputation for research, and developing those partnerships across the region to sort of drive the sort of development and delivery of really strong research, and also empowering individuals to both engage in research and champion, and that's across sort of staff, volunteers, and the residents. And the strategy is now being taken to the 3 CCG governing bodies, so it went to Ipswich and East Suffolk yesterday. Obviously it's here today, and it's also going to North East Essex at the beginning of June, and we're really looking for sort of agreement to take the strategy forward, and hopefully then it will be adopted as we move into an ICD. I'm happy to take any questions or any comments, and so I mean, Lisa might be able to tell you where how research is going to fit within the ICB as we move forward. Thank you.
Well, that's really easy, because fortunately I have Andrew Kelso, our fabulous incoming medical director, who's going to be leading on research. So I'm sure as he becomes more established in role, he'll be wanting to look at the totality of the research portfolio. Thank you.
Okay, thank you. Any questions then for Claire, Lisa, or Andrew? Jeff.
Thank you, Claire, for that presentation. It's a comment really. I'm happy with the paper. I was just a bit surprised, and I apologise if I've missed this. There was no reference to the School of Medicine at Cambridge, who we fund through the Clinical Academic Reserve, or it will be funded through the region, I presume, going forward. Thank you.
Okay, thank you. That was probably an oversight, so we're quite happy to sort of add that in as a link. So, and we do support research coming out of the University of Cambridge. So there is a number of studies that happen, particularly in the Eastern region, that are University of Cambridge led. So,
thank you.
Thank you, Godfrey.
Thanks, Chris. Thanks, Claire, for that presentation. I think the strategy looks really good, but of course this is a crucial time, I guess, in that the CCGs that are engaged in this won't exist, and it is going forward to the ICS board. And I see in 2.7 in the papers that you've sent out for this, that the end of the sentence says ownership of the strategy by SNI will be critical if the ambitions within the strategy are to be realised. So as a principle, that sounds spot on. I just wondered whether there's any thoughts in practical terms yet about how it's going to develop under the new system. Will there be a ring-fenced budget? Will there be certain times when you will check how the thing is progressing, given the changes that are going to take place, particularly in light of the strains that are on the system?
So, I mean, I'll ask Lisa to pick up on a couple of those things. In terms of sort of finances of research, the research networks, the local clinical research networks here in Eastern, funds a lot of the research delivery staff. So in terms of research delivery within trusts and within primary care, there's already an existing infrastructure for research there that is funded through that external money. So we're not anticipating that this will incur sort of additional costs from the delivery of research and the supporting research side of things outside of what's already there. I'm hoping Lisa can pick up on the internal sort of ICB side.
Thank you. So, I mean, I think, as I said previously, there are many elements of research that's happening across SNI, and I think we need to sit down and look at all the different parts. So we've got the ICA, we've got the UEA healthcare partnership, we've got lots and lots of bits going on in different places, and we just haven't had, well, I haven't had the capacity to bring it all together and to really understand for SNI where are our key relationships with the universities, what are we doing, and what are our research priorities in a wider sense, which is why it's great to have Andrew now working with, although as Andrew told me the other day, it's not just about medics, it's about researching nurses and other practitioners as well. So it's important it doesn't just become a medical thing, but we really, there's been lots of work, great work, amazing work happening, but we really need to pull it all together now and kind of get a grip on it across SNE.
Yeah, that's helpful. And particularly, I would think with pharmacies, because a lot of the hard to reach populations won't be engaging with GPs, so won't get access to GP surgery. So pharmacies might be a big area of worth exploring, I guess. You may already be doing that.
Yeah, there is some work ongoing with the research networks around pharmacies, and they have a pharmacy lead person that has been engaging. I think that the slight sort of stumbling block at the moment is that a lot of the research that comes into the region from elsewhere, and there is a lot of research that is coming in from elsewhere, is very much designed to run in hospitals or primary care. And I think engaging with researchers to look at alternatives is something that is being done, but I think it's a slightly slower process. And similarly, there's now more research coming through that's in the sort of social care settings, so care homes, hospices, and the research network is also now sort of branching out to support research in those areas as well. So certainly the kind of research arena is changing, but it will take a few years to kind of be realised. So
okay, thank you.
Zora.
Hi there, thank you, Claire. I've linked in with you before and through my work at the Training Hub, and this is just following on from Godfrey's points, and Lisa has already answered some of what I was going to ask anyway, but it's really the higher educational institutes, the universities, they've got their researchers and they've got their key projects coming down into our clinical world. But and I was just hoping that we could link in and have the clinicians doing research and fellowships, so that all the ideas are coming from what's going on in SNE, in our local area, rather than coming from from up above as part of a physiology degree or something like that, which I know can be very niche in terms of what they're looking for in the research. But really, it's just to sort of make that link and just say we'd like to work with you from and not only as GPs, but yes, the wider workforce as well, to promote research within our workforce, again to improve retention of staff, because I think this could be an interest that they might like.
Yeah, no, that's a really good point. So I think there are fellowships around and available for staff that are interested in doing a little bit more research of themselves. And certainly I know I've been obviously sending you some of the links and trying to promote that, but we can probably do more to promote some of those schemes more locally. There are other schemes that again, the research network produced to help sort of develop workforce capacity in terms of engaging with research. So certainly I'm sure we can explore some of that aspect further and see what else might be needed and how else we can support that locally.
Thank you, Paul.
Yeah, thanks. Hugely exciting, absolutely supportive of that work. It strikes me that we're going through one of the big transformational changes we've seen in terms of organisation moving to an ICB, and I just wondered whether any thought had been given to organisational development and workforce in that sense. In terms of how we structure ourselves, how we move forward, how we use research fundamentally as in our everyday working. And I think that there's clearly for me a link between that and OD, I guess. And I just wondered how that might be captured in the future.
I think there are definitely things that we can look at and to do. I don't think we've not had that conversation as such yet, but certainly I think there are a lot of workforce development opportunities that research can bring, and I think we need to look at what the opportunities are and how we can maximise them. So I haven't got a full answer for you for that.
No, I don't. I
certainly think it's a really important point that we need to capture.
We're clearly at the beginning of the journey, and I suppose my personal take on it is research should be an intrinsic part of what I do, even if I'm not actively engaged in the research. How do we structure ourselves to maximise those opportunities? And that's a hugely exciting area of work, I think.
Yeah, thank you.
Thank you. Andrew Kay.
Thanks, Christopher. I just wanted to support you, Zora, on your comment on practice-based research and research at the coalface, if you like. I mean, if any of you that have set up a research programme in the past will know that research is a really broad church. It covers lots and lots of different areas. It touches on all bits of clinical practice. It touches on routine clinical practice. It touches on transformation. It touches on innovation. Touches on education, touches on retention and recruitment in people. It touches all bits of providing a healthcare service, and actually to make it effective, you need all the bits to work. So you need practice-based research, you need specialist research programs, which can often help fund the other stuff. You need health services research. One of our biggest opportunities in Suffolk and North East Essex is the Integrated Care Academy, which has a research programme of its own, which is growing, and that will also help to work with GP practices and integrated neighbourhood teams to really learn, accelerate the learning we get from developing integrated care across the ICS. So it's an exciting time for research, and actually I'm keen to meet you one-to-one to talk about how we can use training hubs as well to further that. Thanks.
Yeah, we'll link up.
Thank you. Andy.
Yeah, I just wanted to flag up about the cancer, the Cambridge Cancer Research Hospital that's being planned at the moment, and that's a new build hospital that's going to be on the just next door on the Patworth site, and there's going to be a big research element, and we need to, it has got a regional focus as well as a Cambridge focus, so we will need to, that's just in its inception at the moment, so we've had meetings on that, and we need to plug into to get an integrated approach with them, because they're almost like slightly, I think they really want to engage and they're reaching out, so it's a really good time. And then the second point I just wanted to mention, I think it sort of builds on what Paul said and what Zora said and what you said, Andrew, is I think research is, the research I have always found really interesting and the most challenging is, I wouldn't even call it research, it's almost like a project, or it's somebody who within an organization, and often somebody really at the coalface, who brings a little bit of work that's not even called research. It's a little project, and it can sometimes be, it can really alter how you think. And I really think, I actually don't like the word research. I think it's too ivory towery in some ways. I prefer it more like a project, an analysis, an investigation. We need to keep this, we do need to have a grassroots focus to it, and to encourage those people to just really think about their jobs and how they analyse their jobs and how they analyse the operations. So, and it's something that I regret not doing more of in my work. I did a little bit, but yeah, so that's, just put that forward.
Thank you. Richard.
So, Claire, similar comments to yesterday, just so others have heard that. So I think the aims are really helpful because they're broad enough if we do end up making any changes to our ICS strategy, which, just for colleagues' benefits, we'll be going through an exercise over the next 6 months to refresh the strategy. So some of the higher ambitions that are currently in our existing ICS strategy may be slightly tweaked, changed, others added. So I think whatever happens with that, I think the aims still stand the test of time and the outcomes that are put in the strategy. Helpfully, we had an innovation workshop yesterday afternoon across the ICS, and clearly in my head, research, strategy and innovation are inextricably linked. So Andrew and I could be talking further around how we make sure that we're joining some of our thinking up around innovation as well, because there's obviously risk of us kind of going off in separate directions, which I'm fairly confident we won't. But yeah, I think that particularly in terms of the governance, and I say that lightly, around how we look at research, innovation, etc., it'd be key to bring some of that together. But really pleased we've got this, because I think it's been needed for some time, as others have said, and I'm fairly confident the ICB from the 1st of July will adopt it as well.
Thank you very much. All agreed. Lovely. Thank you very much. Right, on to item 10, which unfortunately still, well, unfortunately for you, it's fortunate for the rest of us, still with you, Lisa, the key working function.
Thank you. And this is Bring a Friend Day for me, because Leanne's joined us, Christopher, to present this. It's a piece of work that she's been leading on, and can articulate it better than I can. So I know we have, as a clinical executive, looked previously at the key working function and approved it, but this is just an update paper around the procurement of that. So I'll hand over to Leanne, if that's okay.
Thanks, Lisa. Good morning, everybody. So as Lisa said, this is an update around the key worker function implementation. Just to highlight that the actions that we're coming to talk to you about today is around supporting the recommendation for Suffolk County Council to provide this function in Suffolk, and then to sanction a waiver around competitive tendering on the grounds that there is clear benefit to be gained by this approach. And I'll obviously hopefully just highlight key areas, but I'm hoping that you've all had a chance to read the paper, which will go into much more detail. So as you will all be aware, and I've mentioned before, the key worker function is a response from NHS England, NHS Improvement Long-Term Plan, and it's a commitment that by 23-24, young people with learning disability, autism or both, and with the most complex needs will have a designated key worker. So what that essentially means is this won't replace our usual delivery of services. They will not be delivering services. They will be there to support that family and young person to navigate our system, and they will also be there to challenge us as systems where service delivery is not in place and is not helping support that young person. Because what we're recognising through a lot of the reviews that happen is that a lot of young people, if they had had the appropriate community support in place, we wouldn't then be looking at them needing to access a tier 4 hospital bed. And we all know that there's considerable pressures around that at the moment. So just to highlight some of the objectives. So again, you will know that there's a key programme of work around within transforming care that we have to achieve as part of the long-term plan. So it's again reducing those admissions for our young people into tier 4 settings. It's about helping families and young people navigate our system, and about that holistic plan, so that families are not having to sort of go around our system trying to get support from multiple places. We have to have a dynamic support register, which again is about recognising, we do have this in place, it's about recognising our most at need young people and having that kind of collective system approach to supporting them, again, to get their needs met in the most positive way that we can. We've also got our care, education and treatment review process. So again, any young person that is beginning to move into a space where they may need to be considered for a hospital bed, they need to have that MDT review, and there is a kind of process that we have to, a statutory process we have to follow to ensure that, again, all of that support is in place that is needed. And again, about holding us to account, so holding providers to account where any of those elements are not being delivered, and around escalating and trying to unblock barriers. So that's just a little bit around what the function is about. We have had quite a strict timeline from NHS England around implementing this. There have been pilot areas in other areas within the region, and there has been finances that have been attached to the delivery of this piece of work. So you will see within the paper there is a 3-year financial kind of plan as to what money comes down, so that we know what we've got to spend to put this in place. We have a really tight timescale to get this in place. It was required to be in place by April this year. We are obviously moving towards recruitment, and we've done an enormous amount of work. So this is just to kind of ratify that plan, really. Yeah, so I think that's everything. I suppose it's just the other bit, just to highlight the key elements of why we think Suffolk County Council are the right organisation at this stage, whilst recognising we will you know, review and assess how effective this is as we move forward. They already hold the CRIS, so the Crisis Help Risk Intervention Service. There is a lot of synergies to the key work and function, so there's a lot of corporate structure that we've put in for the CRIS service that can support this. They've got a record, you know, they deliver community health services. They're rated good in all areas of CQC. They've also got outstanding services through Ofsted. They also have experience of managing sort of arm's length services such as Sendias. So again, they've got that experience they can draw upon, and again, attractive terms and conditions. They've got, you know, the overheads are not as expensive as some other providers, and we can put it in place quite quickly. So I'll stop there.
Thank you very much. Any questions for Leanne? Oh, all in agreement and welcome. Thank you very much indeed then, Leanne. Thank you,
everybody. Have a good day. Bye-bye.
Bye-bye. On to item 11 then, the procurement update. Please, Paul.
Thank you, Christopher. I'll keep it fairly brief. I'll take the report as read, but I'll just pull out a few things if that's okay. You'll notice within the report that the mental health assurance bid is been paused slightly, and that's essentially because we need to review any assurance process in light of CQC reports. And I'm sure Lisa later in integrated performance report will talk to that in terms of where we are as part of that process. But I think there are some good news stories within the report. First of all, I'd like to point towards the framework procurement element, and you'll see at a significant level of interest from our volunteer care sector and how they have engaged in this process, and across a number of range of support, you know, whether it be crisis, you know, children and young people, community, learning disability and autism. So it was great to see. And I think it's probably a bit of a testament to our you know, sort of support of volunteer care sector as move forward by having a framework, which will mean that procurement in the future will be slightly easier, slightly more straightforward, and really is a testament to in terms of legacy as we move forward. So great piece of work, and I'm sure Richard may want to come in me to say what other opportunities that might bring for us moving forward. But the other two elements of the report really are around to punctuate the fact that we have concluded the procurement processes for Daytime Wellbeing Hub and Evening Safe Haven, which was awarded to Access Community Trust, and the teams are currently mobilising that service, hopefully to start in July. So again, progressing well in terms of engagement. And then the other element was the Suffolk Community Connector programme, which was awarded to the Anglia Care Trust. And again, the service is currently transitioning, and we're hoping for that to start in July and progressing well. So Christopher, I'll stop there. It's a fairly straightforward report, and I'll be happy to answer any question. Thank you.
Any questions for Paul? Okay, Paul, thank you very much for the report. Okay, we go on now to the next section of the agenda, the finance, performance and scrutiny. And we will begin with the 2022-23 plan report from Jane. Thank you.
Oh, thank you. It's Chair, it's actually a joint report from a number of directors. So in terms of going through this efficiently, I'm going to suggest that Richard starts and we'll cycle through the various sections and we'll finish with the budget, if that's okay.
Okay, thank you.
Thank you, Jane. So as Jane's just described, this is in essence a bit of a quadruple act across the director team. And I think that clearly is clear in terms of the fact that this is our overall planning process for the CCGs. We've got a planning group that meets every couple of weeks that's been in formation for the last couple of years as we've perpetually been replanning with NHS England. And that group has effectively been developing each of the elements that you'll hear us describe in a second. So the first one is the narrative plan that is attached to Appendix A. I'm looking at my other screen, by the way, not staring into space. And that document links to NHS England's request around specific detail around how we're going to deliver against each of the areas they've described in the next financial year, the one we're in now. And just to give you a bit of a counter through, the first one is health inequalities. As you know, that's a golden thread running through our ICS strategy and all the work that we do. But there are specific requests and requirements from NHS England related to health inequalities. So we've set out in detail in the appendix
actually how as a system we're looking to respond to those requests. The second area is workforce that Amanda will come on to in a second to talk in a bit more detail around, but we have a narrative response also to do around some of the opportunities, risks and the planning that we've done around long-term workforce projections. The third area is elective, and that's where Paul comes in, and Paul will talk in a bit more detail around the specific requirements. But in essence, that's around our elective recovery over the next 2 to 3 years. And there are some key performance indicators related to that, again, that Paul will describe in a sec. The fourth area is cancer, which I take a lead on with Narinder Evans in my team. So that's particularly around, again, how can we recover our cancer performance over the next year, particularly related to 62-day waits, 31-day waits and 28-day faster diagnosis. And we've got a clear plan related to that and ICS governance in place to oversee its development and delivery. The next area is diagnostics, which is a shared endeavour between Paul and I. So the first part of it is related to the elective recovery element around how do we build back better in relation to our diagnostic activity. And the more developmental side, which sitting with me, is the development of the community diagnostic centres, CDCs, of which you know within Suffolk, we're looking to develop one in West Suffolk and also one in Ipswich and East Suffolk. It's early days around that, but there's work being led by West Suffolk Foundation Trust around a potential site. The next one is urgent emergency care, which again Paul leads on, and that's particularly split into two elements. The first is specifically our urgent emergency care requirements around ambulance handover delays, 4-hour performance, etc., etc. But the second element is related to community services, so including the 2-hour urgent response that needs to be in place from community services and the development of virtual wards, which is building on a lot of the work we've been doing on discharge to assess and optimise over the last 4 to 5 years. So there are the areas that specifically NHS England wanted us to describe in terms of what we were doing. There's also a separate response on mental health, of which we've also submitted, which talks around how we're going to, again, recover our services, but also specifically the national requirements related to such things as IAPT and wellbeing services, crisis services, etc. You'll note that there's nothing there on primary care, on children and young people, on learning disabilities and maternity. They haven't asked for great detail on that. There's a little bit, but they aren't areas that they've specifically asked us to cover in depth as part of the narrative response. So I'll hand over at that point to Paul, who'll talk a little bit more about the activity and performance element.
Okay, thanks, Richard. I'll particularly focus on obviously the elective and the urgent care element, if that's okay. I think starting with the electives, the one thing you will notice within the plan is that it's pretty summarised in the following way. So there is an absolute expectation that by the end of June there will be no 104-week wait patient waiting in excess of 2 years, and I'll talk about that when we get onto the IPR and to where we are, but essentially that's the commitment, and we have as a system committed to that, which is actually right and proper. The next element is around 78 weeks and having no 78 weeks patients, i.e. 18-month patients, had by the end of March 2023. Now, we've done a bottom-up piece of work as a system, and we fall slightly short of that in our planning. We think there's likely to be about 380 patients at the moment that we won't be addressed by the end of the year. But that doesn't mean that the system is not committed to make that happen. It just means there are further conversations around mutual aid under the processes we might be able to address. This is a moment in time where we think our planning takes us. So again, remains an absolute commitment for the system to get there. And again, it is why that we should be reducing the number of patients waiting a long time on our elective waiting list. In order to achieve some of that, there has been an ask that we should maintain 110% of activity compared to the 1920 threshold. And again, through our plan, we've committed to that. There is also a financial component of 104% of value element of that, and again we've committed to that. So in terms of planning, we are coming to deliver what we've been asked to deliver, and we have plans to back that up. In terms of diagnostics, again, it signals a step up in terms of capacity. So we are expected to work at 120% of that 1920 threshold. Again, we've committed to that. There are some minor areas like endoscopy where that has proven to be a bit of a challenge, but actually we are looking to actually insource some additional support and capacity to close that gap. The question, of course, will always be, does that take us far enough? And clearly there is a long hill to climb. So again, I'll touch base on that in a second. One of the other big plank of the planning is around outpatient transformation. So this is really about managed demand management. So patient activity follow-up. So patients who don't need to be seen, got access to the service should they need to, is very much part of the planning going forward. Reduction in outpatient follow-ups is an expectation. But as a system, we have taken the view that given the amount of backlog that we have, that's probably not achievable this year, but we will carry on working toward that. So we are not planning to achieve the national ask. And to be fair, we've not had much pushback on that. Most people are in that same position. So we want to make sure we are realistic in what we say we can achieve. One of the other central planks is around advice and guidance. And again, that's quite an important part. And there is an expectation that we would see at least 16% will be the ask. But broadly speaking, when you look at the whole thing, a couple of things do come out that stand out. The fact we are going to have to increasingly work as a system, and mutual aid and reducing inequity of access is an absolute key element of this conversation. And I think the documents sort of articulate that fairly well in terms of an approach. And the fact that this isn't just a next 12-month planning, this next 2 to 3 year planning is absolutely key. And you will notice that there is an expectation that we will need to step up to 130% of activity compared to 1920 threshold. And of course, behind all of this will be finances, behind all of this will be workforce requirements, etc. And finally, the only other thing to say around the approach is one of the key drivers will be around productivity and efficiency. So utilization of theatres, make sure only the right patient get to the right place that they need to be. The fact that we need to treat as more patients with what we've got is also very much an element of that direction of travel, and we are getting national support for that, and as are all systems in terms of models and sort of evaluations and everything else. So just to finally close off that bit, we have an elective board, as you know, which actually is charged to actually oversee and help to drive some of these changes across the system. And we have a good foundation as we have been up till now. So that's essentially the elective bit of it. The other side of the coin, of course, is non-elective, and you need to deliver non-elective to protect the elective, and it's a different side of the same coin in some respects. And really, I think that the narratives really articulate the complexity of all of this. So not only does it recognise the need to plan better at place-based and population level to make sure that patients are managed appropriately, and you might want to put into that conversation, the whole GP forward review, the workforce element, the primary care element, all of those things are really vitally important in terms of sustainably moving forward. So prevention needs to be a clear element of that conversation. You'll notice that there is a big change in terms of the virtual ward, which is signalled within a document, which is essentially not about prevention, but I think it's about trying to manage patients who will end up being in an acute setting differently, and there is a fair amount of money that's been made available going forward to happen, and we are in a planning stages for that as we speak, and very much part of our programme. As Richard already trailed, a real focus on our discharges, criteria to reside patient, and trying to maintain that flow is vitally important. And we have to recognise the nature of the integrated, so the nature of the integrated care as well is also vitally important with all of this in terms of approach. And finally, one of the biggest risks, as you know, has been around ambulance delays. And again, there has to be an absolute focus on what we can do to prevent delays at the front door into our approach. The use of same-day emergency treatment as a way of managing, we can turn around patients fairly quickly, etc. So again, quite a detailed amount of narrative. And the final thing I would say is that all of that narrative essentially translates into the active figures, which you've seen pages and pages of it. So that's been triangulated against workforce, that's been triangulated against finances, and that's been triangulated against the active figures, which so the figures that you see now are an expression of the narrative, and that has been triangulated. And we've also had some external support from Deloitte to review the work that we've actually done. So fairly robust piece of work, fairly realistic piece of work. But as Richard already alluded, there's some golden thread running through all of this, like health inequalities is also an important part of that golden thread. So I'll pause there. There is a lot of narrative in there. I think it demonstrates, the amount of collective planning that we've done as a system, and we're now into the process of thinking of delivery and make sure we deliver the ask and our aspirations. I'll stop there. Thank you.
Thank you very much. Any questions for Paul? Godfrey?
Thanks, Chris. Thanks, Paul. That's very helpful, and very comprehensive papers around what's been the amount of work that's been done. I do notice in one of the I think it's on page 99, it says that the West Suffolk Hospital has applied for capital funding to convert Newmarket Community Hospital for 2 specific ring-fenced wards for elective surgery. It then goes on to say it's a pre-business case stage. Is that application for central funding, and is it likely to get a bit more of a push if they talk about the RAC issues? Okay. And are they waiting to see if they get funding before they go ahead and produce the business case?
So I'll begin to answer, and I'm sure Richard and Jane may want to jump in there. So there was a proposal gone forward as part of centralised capital funding called TIF2, I think, from memory. Unfortunately, at this stage, that has not been supported as part of that tranche. So at the point in time this was written, that was the process we were applying for it. It hasn't been supported at this time. However, my understanding is that West Suffolk are still exploring the options in terms of the business case moving forward. And in some respects, there's an element of testing future hospital model as an approach to that. So it's not sort of dead in the water, but it hasn't been supported at this time. Richard, you probably wanted to come in at this point.
I think you've pretty much described it. So there was a limited pot that came to the region as part of a national process. As you can imagine, each ICS put in a raft of different proposals, which therefore the overall was massively oversubscribed. There was a panel process of which I was part of, where we effectively narrowed down and prioritised list of schemes, which was then sent through for agreement at the national level. Unfortunately, many schemes didn't make the cut, including the one Paul just described. So although it's seen still from within West Suffolk FT as a key deliverable at this stage, we don't have an identified capital pot support. But I would agree with the trust. It's worth us keeping it live, so to speak, in case there is another opportunity for further funding.
Yeah. So that plan still exists and is, I don't want to use the term, but oven ready if funding is available. Yeah. Okay. Thanks.
Thank you.
I think we're going to Amanda now.
Amanda. Okay. Thank you. Amanda.
Thank you very much. Thank you, Jane. Thank you, Chair. So in terms of the workforce plan, a bit like Paul has said, we've very much taken a collaborative approach across the system, with all partners in drawing up our workforce plan for the year ahead. And as we will have seen, we are planning an increase in our overall establishment by 5%, with a 2% increase in total workforce numbers by March of next year. The ambition of the system workforce is around having that one workforce approach and programme, and that clearly continues to be a priority of our system people board. And in terms of that, we have 3 main areas of focus: supporting obviously our current workforce, belonging to health and care, and also looking at our new ways of working, including our supply pipeline. So we have a range of activities, something like 50 separate programmes of work that focuses on all of those 3 and more. Another ambition that is going to be borne out further in coming months is our approach to systemic integrated planning, and moving away from our traditional approach where we have workforce planned every year. And this time we are wanting to do something on a longer 3 to 5 year programme and period, and not just focus on the health integrated planning, but also encompass the wider social care agenda as well. So that is going to be something that actually takes momentum and more as we move forward in the coming months. And all of that is going to be delivered and linked into one of our key strategic partners being the Integrated Care Academy. And we want to do a lot more collaboration with them, given they are now, a year in existence, and really their programme of work over the last 12 months has been phenomenal. So we have really great opportunity, and I have quite a lot of confidence actually that we'll realise our ambition on integrated planning through that. And just to give members one example actually of integration and the work we're doing with the ICA, and that's around developing something which we think is quite unique to SNE, and that is the development of an integrated care apprenticeship. So work has begun across the entire system, and we're actually scoping out what that might look like, with a view that we can launch a new apprenticeship across health and social care towards the end of this calendar year. So we're really excited by that, and that work is being overseen by our People Board. So in summary, Chair, a lot of activity, a lot of work, but in collaboration with system partners. And we are quietly confident that over the coming months, we will have something reflective of our system, which deals with the now, but also deals with the future supply of our workforce going forward. Thank you, Chair.
Thank you. Questions for Amanda? Okay. Are we going to you next, Jane?
We are, yes. Last,
okay.
But hopefully not least. We're presenting today a position to the governing body which is part way through a very long and protracted planning process. It's long and protracted for good reasons, because there's been some recognition of additional costs of inflation, etc., which I will talk about. But it's also more complex, made more complex by the fact that when the Department of Health started to issue the allocations, the expectation was that we would be an ICB from the 1st of April. So we received all of our allocations as an ICB. We then needed to separate those out into part year for the CCGs moving into the ICB. So it's so we're kind of part way through something that's quite difficult to actually get hold of. So I've tried to isolate down what it is we need to do today. So what we are looking at today, and it's on the final slide in Chris Armett's very well constructed pack of things, is the 3-month budget for West Suffolk CCG, which will take us up to the end of June, as an opening budget, and that's what we're asking the governing body to look at today. So I'm going to tell you a little bit of the story about where we've got to where we are and what's happening overall on CCG and ICB budgets. But the good news for the CCG element, because we are effectively a part of a part year, if you see what I mean, for the ICB, the way that this is going to be treated at national level is that the expenditure we make in West Suffolk CCG will be matched by allocation from that overall amount of resource that the ICB will receive for the year. So by definition, the CCG will have a balanced budget for months 1 to 3. Obviously, if we spend more than we were expecting, that has an impact onto the ICB. But in terms of what the CCG needs to approve, the good news is we're looking at approving a balanced budget for that 3-month period. And the final slide that we've put in there sets out what we expect that to be, albeit with the provisos I'm about to talk about, that things are still moving around. So in terms of what's happening, when allocations were agreed for the Department of Health by the Treasury, they were done in sort of late summer, autumn time. And as we all know, things have changed. Assumptions, particularly around the level of non-pay inflation, and also about the expectation at that point that COVID would be something in the past and there would be no impact in terms of NHS costs for COVID during the current year. Well, both as we know, non-pay inflation is high and growing at the moment, and obviously that has a knock-on impact into a lot of the costs borne both by ourselves as a CCG, but also in our provider organisations, for which the funds flow through via the CCG. And we know that there was a wave of COVID which had an impact on activity and costs, pushing into April and parts of May this year. So as part of the planning round, there was recognition that the allocations didn't necessarily cover that. So as part of the latest submission that we made in April, all areas were asked to reflect their best estimates of the costs of those increased inflation and COVID as part of the planning round. And the slides that are included in the pack that show that when we did that work and looked at the monies that were coming to the system and what was left for the CCG ICB element once we passed out the cost to our providers, that left us with a shortfall of 18.5 million, and that's shown on the final slide. Obviously, well, you could break that down, and I think it's in there on the slide before. That breaks down into around about 5.5 million that we attribute to the excess costs of COVID, particularly the dropping out of the hospital discharge programme impact of that, and around about 13 million to do with higher non-pay inflation. So the good news is that across the country, the similar figures have been submitted, and similar figures from our provider organisations, from the rest of the region and from other regions nationally. And the Department of Health and NHS England have looked to see what other resources can be released out to systems in order to try to close the gap. So on Friday last week, Ed received a letter setting out that some additional funding is coming to all areas, including Suffolk and North East Essex. Most of that will come via ourselves to go through to providers, particularly including the ambulance trust that we host, but there will be elements of that that will be retained to recognise cost pressures within the CCG ICB. So the total sum for Suffolk and North East Essex is around about 17 million recurrent and about 7 million further non-recurrent, which is effectively around COVID. Now, obviously, not all of that will stick within the commission, and most of that will go out to providers, but it will go a long way to helping us to close the system gap. So we are now working through, Chris and the team are working through with our local organisations how that additional funding will be allocated. Most of it's pretty prescribed, but there are some bits that we'll be looking to distribute on fair shares element to our local providers. And we're then looking at what impact that will have on our overall finances. So unfortunately, the music hasn't stopped yet. We still have further work to do, but I'm pleased to say that hopefully we're getting close to resolution. So what I'm asking the governing body to do today, I'm afraid, is a little bit of an unsatisfactory position, but it reflects where we are. If we can approve the opening budgets as set out in the paper, because we need governance for that to be able to upload those onto the ledger and to start doing our reporting for the year. And if we can delegate to the finance committees, we've got one set up in 2 or 3 weeks' time to hopefully be able to present back the results of those last few changes and the application of the additional funding, and hopefully be able to present a balanced budget for the full year at that point. So that's the overall request. Chair, apologies that was a little bit long, but obviously happy to take any questions.
Any questions for Jane? Oh, I think that's accepted then. So thank you very much. Lisa, have you got anything to you want to say in section 12?
No, I've got nothing further to add. Thank you, Christian.
Okay, thank you. Okay, well, it sounds like that we are very happy and very grateful for the work that's gone into that plan. And we look forward from wherever we happen to end up at that time to see it being rolled out and enjoying the fruits of it. Item 13, the Integrated Performance Pack. I think who's going to start there?
Shall I kick us off? Thanks, Chair. Okay, so it's a bit of a theme today, isn't there? And so I'll start with give a bit of an update around the electives, really, because I think clearly it's an important element of our performance. Just obviously the report is essentially a March report, but what I'll do, I'll give you a few more updated figures as they are as of almost yesterday, even to late last week, really. So I think the first commitment, really, as I've mentioned previously, is around 104-week waits, and actually making sure that we do not have any patients beyond 2 years waiting times on our waiting list, unless, of course, there is an absolute patient choice, which is a different conversation, I guess. So as we are now, there are currently at the West Suffolk 150 patients that are actually above a couple of years, and there are plans to address that by the end of June. Now, I say that with a slight caveat that that West Suffolk have experienced a slight further delay in some of their remedial work within their theatres, but they are currently working on mitigation plans to make sure we carry on achieving what we said we would achieve. That's been monitored on a weekly basis, almost daily basis in terms of communications, and they remain committed. It's fair to say that the mutual aid has carried on quite significantly with support from our independent sector and from SNEFT, and it's really interesting. Late last week, I looked, because I hadn't looked at it for a while, the total number of patients which sort of moved around the system collaboratively. And that's in excess of 1,000 patients have been managed either through, our independent sector or through mutual aid in one way or another. A large proportion of patients about 240 odd patients were orthopedic patients, and quite a large proportion of that went to SNEFT in terms of mutual aid. So again, some great example of joint working around that piece, and that will carry on, and I need to step up further in terms of moving forward and the challenges that I articulated earlier. So that commitment maintains. In terms of 78 weeks, we have started to monitor our plan as was detailed, and we are slightly ahead of trajectory, which is great to see, and long may it continue, and we will carry on monitoring that. But clearly, the areas of concern remains orthopedic, gynae, and I think if you look at numbers, general surgery is up there in terms of concerns. But again, so will be a clear focus in terms of system and what else we can actually do. I think really interestingly, the report identifies the inequity in access. If you remember, when we started this journey, we had really significant inequity of access. And you'll notice in around ophthalmology, we're down to 1 week now. The report highlights the fact we've gone from, in terms of the 92nd percentile, that's really important, we're down to 8 weeks from 11 weeks in the previous report, but actually as of yesterday, we're down to 5 weeks. So again, we are seeing inequity of access reducing significantly. In part, this is due to orthopedics because some of the theatres capacity is reopened at West Suffolk. So again, we are seeing some of the benefits that are moving forward. I think the things that I would say, though, is whilst we are improving our over 1 year position, whilst we are improving our long waiters, what we are seeing is a continued growth in our overall waiting list. So again, that plays to the conversation we had earlier on to say we need to go further into efficiency and capacity in terms of our longer to plan to actually make our waiting list and elective activity sustainable as we move forward and recover from the effect of the pandemic. Both Trust and certainly West Suffolk as well remain absolutely committed in meeting the outpatient transformation elements in terms of PIFU, which I've mentioned before, i.e. patient activated follow-ups and advice and guidance, and we are monitoring that as we go forward. So essentially, we are seeing some good progress, but I would say the challenge is starting in terms of maintaining and sustaining and getting back to where we were pre-pandemic, not forgetting, of course, that some of our waiting lists were out of shape before the pandemic. So again, we are managing some historical challenge at the same time, but essentially some really good progress and some further work to be getting on with. In terms of urgent care, just as of last week, nationally, we have stepped down from a national incident level 4 to national incident level 3. Now, that's great news, but essentially in terms of our, in terms of the way we organize ourselves and respond doesn't change very much. We still maintain certain levels of emergency, so structures to try and manage what has been a very, very difficult few weeks. As Ed had already trailed, We had 10 long days where we were at what we call OPAL level 4, which is an escalation level 4 being the highest level of escalation you can be, and 1 being everything is running really smoothly. And whilst we've dropped consistently down to level 2 in the last week or so, it still remains very pressured in the system, as you can see from the markers in terms of performance and everything else. But it certainly feels a lot more manageable than it has done in recent weeks. In terms of some of the main drivers around the difficulties were clearly COVID numbers within our hospitals. And I think the figures that's quoted in the report is in excess of 150 patients. I can report as of yesterday, across system, we only had 62 patients across our hospital side. 29 of those patients are in West Suffolk. And I think if you look at Ipswich, which has been the lowest number they've ever had, about 14. So again, what we are seeing is a reduction in the number of COVID patients that we have in the hospital sites, which of course which improves on workforce, because the effect on workforce improves and makes sort of flow of patients through the hospital easier in terms of lost capacity and all the things. But it's fair to say we need to keep a watchful eye and trust are continually reviewing their IPC, so the infection control measures, to make sure that we are vigilant, because clearly COVID has not gone away. It's just that in terms of reputation in the hospital, it feels easier than it has done. We have maintained our patient flow fairly well. You see from the report, West Suffolk in particular has managed to maintain the criteria to result numbers at a fairly low level, and that's testament to the joint working at alliance level, partnership with our local authorities, and the focus we have on discharge as we move forward. The thing I would be amiss not to mention is clearly whilst West Suffolk are undertaking their resilience work on the RAC issue, it does mean that they've got a bit of resilience risk, and we are having conversation with our regional colleagues to make sure, in terms of potential diverts and everything to the hospital, this is closely monitored, so we make sure that we recognise the challenge that they have at the moment. So Elisa, you wanted to come in?
Thank you. Sorry, I just wanted to point out that although West Suffolk's numbers of COVID patients appear higher than ESNEFT's, it's because they've adopted a different testing strategy. So West Suffolk, because they're a state, it makes it harder for them to manage outbreaks and contacts. They've continued to test asymptomatic contact patients, so they are finding more COVID patients because their testing regime is different to ESNEFT. So I just wanted to make that point clear, that actually they probably haven't got more COVID patients, it's just that they know about them. Thank you.
Thank you, Lisa. Really helpful. I suppose what I would come back is, in real term, the numbers have reduced into where they were. But absolutely right. I think we absolutely need to remain vigilant, and as I said, all hospitals that are closely watching their infection control measures and move forward. The areas that I guess I would point out in terms of urgent care as remaining significant concern is around ambulance sort of response times, C1 and C2 in particular. You'll notice that as a system, we are doing everything we can to support EAC in that endeavour, and in particular, if you look at West Suffolk in comparative terms, whilst there are still some lost hours, they are very low compared to the rest of the region and our system. So again, I think that's testament to West Suffolk in terms of the focus they're putting on making sure that we don't have any undue delays, which of course means lost hours, which of course means access to patients in terms of getting to patient when the call is made. In terms of other support, we are working very closely with this, particularly through 111 in terms of disposition, which again is an important part of our strategy. But at the same time, we've been working with these to try and develop, which is well, you could call it innovative, but actually to me it's common sense. When we have patients waiting to be accessed by the ambulance services, patients are waiting in what we call a stack, which is actually a waiting area, if you want. And on a daily basis now, we're working with these to see whether we can redirect patients from that waiting to the space into some other emergency and urgent care response within the system. So rapid response, GP federation, all of those things. And we are being able to move quite significant numbers of patients away away from that waiting area. Of course, we would like to move further forward and hence that approach. And we are having some regional conversations to see whether that can be replicated across the region. So again, a lot of support for ease into ambulance conveyancing. And as I'm sure Lisa will probably mention later, we have seen a reduction in SUIs, but clearly the waiting times are far too long, and we need to be really mindful, and we need to make sure we carry on improving that performance. So broadly speaking, I think the system feels a bit easier. We are seeing, I hate to say it, some green shoot of improvement, but it remains pressured. The focus remains on improving our performance, and has already been sort of trailed by Lisa earlier. We have just launched our urgent care committee across system to keep tabs essentially on the relevant development required and performance as we move forward and transition from what is a tactical COVID structure to a business as usual structure in terms of performance and focus on improving the flow to our patients. So I'll stop there, and happy to answer any questions. Thank you.
Andy.
Is it all right if I just mention a little bit about the cancer work stream, Paul?
Yeah, absolutely. I was sort of expecting Richard and might step in, but absolutely there are some improvements, as you can see within the report. Yeah, just one or two things that are of interest to across the board, but also primary care. The three pathways that have struggled have been skin and breast and colorectal. Skin has improved markedly with the new skin analytics Telederm service, and 2-week weights percentages have transformed very quickly. Breast, Jane Aitken is looking at a new breast pain pathway, and Jane always works hard to get her waiting list down, and I'm sure she will do. And we're meeting later today about the pathway. So I think breast will improve. Colorectal has been a struggle nationally, and partly due to endoscopy services being constrained at the time of the pandemic. There is, with the advent of FIT, which people nationally will begin to understand how it works, there is a call now for increased prioritisation of FIT testing in primary care pre-referral, and a letter has gone out this week about that to the ICS primary care leads and to the practices about that, and that it is a change in practice and is backed up by new imminent NICE guidance and the British Society of Gastroenterology for that. The West Suffolk really struggle though with their colorectal, and you mentioned it in your report, Paul, about the CT colon. They're really struggling with CT colon capacity, and Antonia Wells, the clinical lead there, we know about that, and she's really, if we can get some help with that, that would really help their throughput. Good news for West, I think is coming. I heard last week we wanted to have direct access colonoscopy for primary care in the West. They have it in the East through In Health in Ipswich, and we are putting some money in to get that capacity for the West GPs as well, so they can have access to direct access colonoscopy. It will be in Ipswich, but it's a fantastic little unit there. I've been there, and it's a really efficient little unit. I'd be very happy to go there, and I hope that that's going to come through on stream in the next few weeks, which will help us as GPs. And lastly, we've done some, Richard's mentioned about innovation. We've done some innovation. We put some innovation bids in. There's some money come down from the Cancer Alliance for innovation, and we've put in for bids, and we had a lot of applications for innovations, but these are three good ones, I think. See the Signs is a primary care prioritisation referral tool for cancer patients. It also manages the referrals, and it also tracks the patients through secondary care, so it really helps with our safety netting. It's a good tool.
Secondly, CytoSponge, which Craig Vickery has been doing a lot of work in the West Suffolk with. We put in a bid for community CytoSponge to help with reflux patients and also Barrett surveillance. And lastly, we've got the skin analytics platform that I mentioned previously, but we're going to trial a community use of that in a community hub, probably Clacton. But that then might supersede. We can then transfer that across in the future, because we know our Vantage Rego Telederm contract is running out. We extended it this spring, and it's going to run out next year. We need to have an alternative to that, and maybe a community provider to provide a teledermatology service for primary care, as well as the service for 2-week waits in West Suffolk, would be a real step forward. And lastly, just to update you, Craig Vickery's been doing great work on an upper GI pathway. We've struggled with pancreatic patients for years, and this is the first time we've actually got something that really is quite useful, whereby we've got interlinkage with those patients going down the endoscopy esophagogastric pathways and those people needing CT for pancreatic, and having linkage and triage and follow-up across, so that patients don't go down the wrong pathway. So he's worked hard at that, and I think that should be coming through fairly soon. Thank you very much.
Thank you. Any other questions? Paul, I'm just looking at the arrival to handover and the trends of lost hours in the pack. Given that West Suffolk's doing well, and given that I thought I understood there was some money coming into the system, partly to be passed on to the ambulance system, and wondering where that should best be put, I just wondered why we were getting bad ambulance performance in West Suffolk, when I thought it was handovers that largely contributed to poor ambulance performance, and ours are quite good.
I think it's a difficult question. I think we certainly can contribute as West Suffolk in terms of reduction, but if you look across the region and you look at the regional pressures, you'll see that there are many hours that are lost with ambulances. That causes invariable delays, and what you have is a regional flexing, should we say, capacity and demand, and then what you end up with are lots of diverse all over the place because other areas are struggling. So there is an intrinsic link between regional performance and local performance. So it's all about workforce, which of course is easing at the moment, but it's also about overall capacity, overall demand. So we can do what we can as a system, but ultimately we are impacted by wider performance elements in terms of response time.
If there is money to go in, should it be directed at that handover point, or should it be directed at somewhere else?
Well, handover point is a reflection of how quickly the hospital can actually offload the patient at the front door. So when you talk to SNEF, or when you talk to West Suffolk, there are certainly all have got some what we call internal system escalation processes that try to actually move, if you want patients quickly into and then release the ambulances. So all this is really linked to internal patient flow, discharges, and capacity and system and processes within the hospital itself. Now there has been conversations around cohorting patients, which personally I don't feel is particularly favourable. There has been conversations about putting additional structures into the hospital to offload patients. I don't think that's necessarily where we should go, but there has been original conversations around some of that. So ultimately, it's about making sure we maintain our flow to be able to offload the patients as quickly as we can to reduce delays. And then on top of that, there is a conversation about are all the conveyances appropriate or not, or can it be managed differently? On the money front, Jane, I'm sure you might want to come in.
Jane.
So I presume, Christopher, you're cross-referencing to me mentioning that there was more money in the latest settlement for ambulance trust. So that is a number of things that the ambulance trust was expecting, including some more money for call handling and for winter pressures. The Ambulance Trust overall, as we know, because they're part of our system control total, has struggled to achieve financial balance over the last few years for a variety of reasons. Some of that is all around largely around workforce issues, etc. So we aren't in a position to direct exactly what that money is for, but I know that the Ambulance Trust is well aware of the issues around handovers and is working with the systems to do what they can.
Okay, thank you. Barham.
Yes, thank you, Christopher. Question for Paul, please, if that's okay. I think last month we talked about the ambulance performance, and I think you mentioned that Paul Marshall will be invited to come and talk us through the issues, and I just didn't know what platform was he going to be invited to, and yeah, has it happened?
Yeah. So thank you, Bar. From memory, he was invited to the clinical scrutiny committee, but unfortunately at that time wasn't able to make it. Is my recollection. So that did happen. Paul is hooked into the current TCG tactical system conversation. He's represented at the UEC committee that we've now set up, and he will also be working directly with the alliances in terms of those conversations. So he's well plugged in, if you want, to that conversation, and also our operational hub on a daily basis. So he is our system representation. He is there. He is relatively new in post, but he's engaged into what we're doing. So we are, for example, having conversations with him at the moment around, and Jane, I absolutely get that, the money is allocated and we've got very little choice. The sort of conversation we're having is, can we use their resources differently at system level, which is another way of moving money around by saying we can work differently, bit of conversation. So all these things are happening, but Bam, you're absolutely right. We did commit to inviting Paul. He was invited, wasn't able to make it at that meeting, and now we need to make sure he's plugged into the new structure moving forward. I hope that helps.
Thank you. Paul, your hand is up. Do you want to say something in your own right?
No, I said what I was going to say. Thank you.
Okay.
Thanks.
Sandy.
Yes, we met with our local ambulance leaders yesterday at the Alliance Operational Group, and clearly the biggest opportunities that they were articulating were around conveyance avoidance. And obviously that will have a direct impact on handover performance, but that was the greatest opportunity they felt for West Suffolk system that we needed to be addressing, is the conveyance avoidance. So that was the priority area that we've put into the plan locally.
Thank you. Okay, I think that's your section concluded, isn't it, Paul?
It is for me. Thank you.
Thank you. Lisa?
Thank you. So I will just highlight a few areas. I think it's probably important just to talk through the oversight process for NSFT from following the CQC report. So as Ed said in his introduction, CQC have rated NSFT as inadequate, and they served a warning notice with 108 must-dos to be completed by the Trust, which the Trust are obviously working through. The must-dos cover a range of services and a range of issues. I think it's important to say that the inspection did find some areas with improvement, particularly our learning disability services in Suffolk, but they found more areas where deterioration in performance and quality was noted. The report covers both Suffolk and Norfolk counties, and it's incredibly difficult to extract what is a Suffolk commissioned service and what's a Norfolk commissioned service, apart from our LD service, which is we only, Suffolk are the only commissioners that commission LD from NSFT. So the overall rating was inadequate, but the Trust was rated as inadequate for safety, effectiveness and well led, which was a decrease in ratings for them. They requires improvement for responsiveness, which is the same as previous inspection, and good for caring, which again is the same as previous inspection. The CQC recommended that the trust remained in category 4 of the system oversight framework, which is the recovery support programme for NHS trusts that are facing their toughest challenges. So oversight and intensive support is led by NHS EI, and there's obviously significant involvement from both our system and the Norfolk and Waveney system as commissioners and stakeholders. So we're all working together. We had the Quality Summit yesterday, which was incredibly well attended by all colleagues across Norfolk and Waveney and Suffolk, and we saw the first draft of the improvement plan, which is looking really at the root causes of what's driven some of the challenges that the organisation faces around quality. The improvement plan focuses on 5 areas: safety, service offer, demand and capacity, culture and engagement, and governance and leadership. And as a collective, we are just looking at how we will be supporting NSFT with the improvements going forward, but we've made some recommendations to NSFT around how we may be able to support them. The improvement plan oversight will be through a weekly improvement board, and again we will be well represented with myself, Andrew and Richard attending the improvement board to support NSFT with the improvements needed. I think that's probably all that I will say around NSFT. We do still see some challenges around waiting times, which you'll all be aware of and are well versed within the performance pack that you've got. And West Suffolk Hospital are recently experiencing some increase in adults, particularly presenting in mental health crisis to their emergency department. So we are just working with them on that. From moving on to E-East, as Paul said, some of the performance has improved. We have seen a reduction in incidents reported with catastrophic harm or serious harm, and we've only since the end of March had 1 reported across the east of England, so that does demonstrate improvement. We were seeing kind of through the winter months, we were seeing around 3 a month in Suffolk and North East Essex where there had been serious harm caused due to system delays. So it is an improvement in the harm levels that are being reported as serious. You will possibly have seen there has been some media coverage relating to misuse of social media within E-East. Obviously, there's limited that I can say about that, but just to give you some assurance that E-East has taken it incredibly seriously, this misuse, and the Don is providing me with weekly updates on the investigation process that's happening with those staff members. From an IPC perspective, we are really sort of, as Paul said, the number of COVID cases are reducing, so we are diverting our attention a little to the rest of the IPC world. Karen Egan, who is our Associate Director in IPC, is doing some amazing work. She started with us a few months ago, is doing some great work in really collating the data so that we have a great oversight of some of the other infection issues that we need to get to grips with a little more. Particularly our post-infection review process within our providers has slipped a little, so we're doing some work to improve that process and to align it across the ICS so that the same template's being used. And obviously at the moment we are turning our attention to making sure that we have robust processes with monkeypox. There has been a number of national and regional calls around the requirements of us as a system to make sure that we are absolutely in the best position to respond should we have any possible monkeypox within Suffolk and North East Essex. I just wanted to update you on learning disabilities and autism. For one particular reason, we previously have had into our clinical executive and private governing body a paper around an independent hospital that provides 12 beds for people with personality disorders and disordered eating, or ASD. We are host commissioner for that hospital under the Safe and Wellbeing Review host commissioner arrangements. I just wanted to update you that there has been a CQC inspection into that facility, and it has been rated as inadequate for safety. So they have been issued a warning notice under section 29A, and we've had a quality visit jointly with the national team last week, and we will be keeping oversight of the improvements required. We don't actually commission we haven't got any people from Suffolk in that facility. This is just purely as our host commissioner arrangements. And the final update I was going to give you was around maternity. So obviously we've had Ockenden 2. We did an Ockenden assurance visit to West Suffolk Hospital a couple of weeks ago with the national team and the regional team. I'm just waiting for the report from that, but it was an incredibly positive visit. We saw lots of improvements that have been made, massive improvement in the leadership, the clinical leadership, and some great best practice examples. The national team were incredibly impressed with the maternity safety huddles that they have in the delivery ward. So lots and lots of really great stuff. So I will share that report as we get it, but it was really to assure ourselves that all the actions for Ockenden 1 have been implemented. We're waiting. The trusts have started benchmarking themselves against Ockenden 2. They're RAG rating themselves, and I think it's fair to say across the ICS there are a number of red actions, amber actions, and possibly fewer green actions. So there will be more work that we need to do. It's a massive piece of work, the maternity transformation programme. I think there's 38 pieces of individual work that's happening. We are just finalising the maternity strategy. We have an inequalities 5-year plan, which is overseen by our Maternity Inequalities Board, which has around 30 different communities represented through that board, and they are supporting Terry, our clinical midwife, with the delivery of our inequalities plan, but lots and lots of work happening there. And we've appointed a digital lead to develop our maternity digital plan with Kate Walker, and we've commissioned a board review of the LMNSB because we feel that there is probably some learning for us as a board around how we function as a unitary board, and really make sure that the assurance oversight is felt across all of us and people aren't representing just to give us updates. So that's some great work. Continuity of carer, we still have 3 teams in the West, and we have a trajectory for them that looks to deliver increasingly more. With the final, we'll get to 100% within 18 months. So Karen Newbury, the head of midwifery, is very, very signed up to delivering the continuity of carer work. I think that's probably it, but thank you, Christopher. Happy to take any questions.
Thank you. Any questions? Jeff.
Thanks. Thanks for that update, Lisa. Very, very informative. I'm coming back to NSFT. I know this is our probably final governing body, but when I came onto this 5 years ago, NSFT was in the same situation as it finds itself now in special measures or thereabouts. We've had various recovery plans, improvement plans. We've had NHSE, us, whatever the trust's been doing, trying to support improvement. And yet I don't see a lot of change. So I just wonder what has to happen to make this organisation and the life for patients much better than it currently is. Have some of the improvement plans, you talk about 108 action points of this plan, etc. And there's been loads of them before. Have some of the ones that's been ticked off as being done have now been undone, as it were. I just wonder what's got to happen to make this organisation fit for purpose. Thank you.
Thank you. That's probably a wider question that I might refer to Ed, but just to answer your question around have we seen a repeat in areas of quality concerns? Yes, we have, which is why the governance and leadership is a really critical part of that. So, for example, ligature risk, we know that we've seen, and ligature risk is a constantly evolving risk. We know that, that it changes all the time, the way that we need to risk assess that. But there have been, I think when you read the report, some of the concerns are not just about the basic practicalities, it's about the oversight and the governance. And I think that's the root cause that the organisation has identified itself, that it hasn't had clear processes for overseeing some of the things that's happening on the front line. So that's what's part of the improvement plan. A really good question about, and that's a question that a lot of people have been asking, what will be different this time? And I think that's the question that we all need to grapple with, around what will be different this time, and how do we support NSFT as an ICB to make sure that people do have safe care in the future. But I don't know if Ed wants to add anything to that.
Yeah, thank you, Lisa.
I mean, it's the big question, isn't it, Jeff? I mean, the NSFT colleagues yesterday was saying that there would be a big difference in terms of their transparency and how they want to actually work with people much more collaboratively on the challenge, and that would be really refreshing if that's the case. And I believe they're very committed to that. But we need rapid improvement. We can't be inadequate any longer. The strategy we've got in Suffolk is to looking at building a very strong collaborative about how all partners can support the delivery of mental health, and that's something that we will be pursuing to the Integrated Care Board. But as the chair of NSFT has said there, this is their last chance to get it right, Jeff. And so it's really vital that we make the right decisions and we see some improvement for the population that have not been well served.
Okay. Thank you. I look forward to that. Thank you.
Any further questions? Andy?
Yeah, I just my concern is I think you meant the collaborative and the work that Richard and the team have done about trying to build this collaborative structure for mental health, I think, has been fantastic, and is really potentially is the long-term vision. And I'm just worried that with this, and I think NSFT obviously are in the last chance saloon, but that in going into the last chance saloon, that could blow off course the fantastic work that's been done amongst the mental health work stream. So that keeping that balance, trying to get NSFT boosted up, but at the same time keep that great work going is for me as much of a challenge as NSFT actually.
I absolutely agree with that, and I think that's the point that Lisa made yesterday is the capacity to get your arms around all of the issues, not only the immediate improvement issues, but the strategic opportunities, and that is why we all need to be supporting at this moment in time, because a single organisation just cannot do it all on their own, given the gravity of it. So you're completely right to identify that as a risk, definitely.
Thank you. Any further? Okay. Now, Richard has left us, and what I propose we do is to take a coffee break until 11:15, if you're comfortable with that. We could then do integration and finance, by which time Richard will be back. I think we've got enough material to make it worthwhile taking a break at this point. So if I see you all again at 11:15, please. Thank you. Welcome back, everybody. Oh, you are there. Excellent. Strategy and transformation we'll leave just until Richard comes back. Director of Integration, Sandy.
One moment, please. I've just got a few technical.
Okay, yeah, yeah. Jane, do you want to step in? I think that's probably best, and then we'll go back to Sandy and then back to Richard.
Yes, no problem. So included at the end of the integrated performance review pack is the financial position, and we're at the point in the year where we're reporting on the full year results for the year that ended on the 31st of March. So this time, you, instead of getting the year to date and the full year, just get the full year position, and you can see overall that between our recurrent resources, non-recurrent, that we received last year, and elements of retrospective top-up, overall we had 487.8 million to spend, and we spent effectively that amount. The difference between the two was around about 13,000. It does show as a small rounding on the table. Where you can see in the report that there were variances up and down within that, which are explained in the second table. We're obviously now in the final accounts process. The draft accounts have been produced, and we are working with our external audit at the moment, and there are various audit committees and governing bodies in the diary to deal with that overall process. Just to say, in case we don't get a chance later, I will be circulating a copy of the draft annual report around fairly soon. If people could have a look at particularly those areas pertinent to you in the remuneration reports and committee attendance, etc., because when we actually get to the governing body for to sign that off, we have very little time to make any changes. So if I could just ask people to just give it a quick look over, that would be brilliant. But yeah, so coming back to the overall financial position, yeah, pleased to say that it is on track for a break-even position, and we have a finance committee planned in a few weeks' time. We'll take you through more detail on that, and obviously build on the discussion we had earlier about the plans for 22-23.
Thank you. So when will be the governing body meeting that signs off that report?
So that is a short meeting. I think it's the it's in about the 15th. I'll just have a quick look on my calendar.
Okay, fine. It's scheduled and we know about it. That's fine. Thank you. And it's a part 2, is it?
It is, because yes, and then we take it into part 1 later in the year in line with NHSE's timetable.
Barham.
Thank you. Sorry, Jane, I was just going to ask you a question about, you touched on the inflation and the effect on the, providers. I just wondered, how do you see, or I know it's difficult to predict how NHS England will actually provide funding, but when do you see actually they will pick up and take into account all the costs that providers are incurring, including, across the board, really?
Okay, so so as I mentioned under the planning paper, there was quite a big exercise across the NHS looking at inflation costs overall. Obviously, that included where we've got known values of contracts and where we've got expectations that contracts are funded on RPI, CPI. We tried to take those into account. So as I said earlier, some additional funding is being provided for that, and where that is designated for providers. For example, it's something like 0.7% additional on tariff price, which will flow through into our main contracts. Where it's a fixed contract, if you're asking specifically about primary care, there's nothing specific in the funding that we've been given, so we will be expecting to fund the contract values as already agreed, which were already causing a pressure on the budget. Obviously, if we've got separate contracts with primary care that are related to inflation, we will take into account whatever the latest rate is.
Okay, thank you. Any further questions for Jane on finance? Okay, thank you. Sandy says she's back now, so if we could hear about strategy and about integration, please.
Yeah, my sincere apologies, but I had a few technical issues. Yes, so I'm pleased to say that progress against all the key priority areas is good. Clearly, our focus is ensuring that some of the areas that we've resourced in year, such as the enhanced integrated neighbourhood team, that we're getting value for money. So an evaluation for that has now commenced. The funding source of that through the Ageing Well programme, as Richard said in his update earlier on, that is a national mandated programme of work that is a must do, and most of that investment that we get drawdown nationally has gone into the enhanced int. So it is an important area for us to ensure that we get right. So the evaluation of that is commenced, and we should get the report towards the end of the summer. The development of virtual wards that, again, Richard talked about in his update earlier on is also a key component of our local strategy and a national must-do. We're really pleased with the progress that we've been making as a system around the development of virtual ward, very much a whole system co-produced piece of work with frontline clinicians and practitioners, and we're confident that we're ready for our submission as part of the ICS on June the 6th. And we had an update at our first operational group meeting yesterday about that, and very positive progress. The key focus for Flow is around getting a sustainable model of discharge embedded into our business as usual ahead of winter. A lot of money was invested over the COVID period in discharges. That money is no longer available, and that does cause some significant challenges for the system, but work is in train across the acute and community interface to get our discharge pathways absolutely robust ahead of winter. We're not expecting any, or we're not preparing ourselves to expect any additional financial drawdowns to support us over winter. We suspect that might come, but our expectation is that we want to build a sustainable system as business as usual and not have that dependency on funding. Elective care, good progress has been made overall. The outpatient programme has 3 core elements. One is around improving our advice and guidance. The MGUS pilot has now been launched. We're pleased to say that 3 patients have now been referred with a new diagnosis, and the team are working and engaging with primary care on that. That is the pathway that James Heathcote came to present to the CCG exec some time ago. Patient-initiated follow-up. Again, this is a national mandated area and puts responsibility back to the patient about their choice of follow-ups going forward. This still remains a challenge for West Suffolk Foundation Trust in terms of reporting. Fantastic progress has been made across specialties in terms of the engagement and sign up by the clinical teams, but the recording of PIFU remains a challenge, and that's something that we've highlighted as a risk at the hospital and are pushing for a resolution ASAP. We believe that performance overall against this is good, but we just need the data to back that up. And the third element is around improving virtual consultations. We've seen a slight dip in performance around the use of virtual technology to support consultations, and that's been mainly around the confidence of the clinical teams, particularly the consultants, in the technology. So they are looking at a solution with Teams, and that's, I think, coming to conclusion very shortly, but certainly buy-in around that approach, and we just need to bring our performance back up to where it was. As a system ahead of winter, a big key theme, which we discussed at the Alliance operational group yesterday, was around the focus on demand management. Urgent emergency care obviously is a key factor in that, but it was also looking at the demand that we're putting on our care sector, which is currently under extreme pressure and unable to respond to the current level of demand. There's work in progress with Suffolk County Council to try and get that back on track and look at new innovative ways of sustaining the care market and supporting the care market. But our demand on the care market has increased significantly throughout the COVID period, and it continues now still. And we need to look at whether or not we're making the right choices for people following discharge and admission avoidance, and looking at alternative ways in which we can support people to stay well and independent at home. So overall, Chair, some really positive, good progress by the system partners in the priorities outlined in the report, and we're not complacent. That we've got a lot more work to do, but as we stand at the moment, we're happy with the plans that we have in place.
Thank you very much. Any questions for Sandy?
Just to say, it's really encouraging to hear the Alliance in action. It's really excellent work that Sandy's leading, so thank you.
Thank you. Right, which is not quite back yet, so I think we will move on to the rest of the business and come back to ask him if he wants to add anything. So we will go on to the Governing Body Assurance Framework. Amanda.
Thank you very much, Chair. So here we have our most recent risk register, and as we can see, we have 15 live risks that we are continually actively pursuing. A lot of the risks we have actually covered earlier on in previous reports, but I just wanted to update on a couple if I may. So the risk pertaining to the white paper, where we have a current risk rating of 9, just to really assure the governing body that with 40 plus working days to go before we transition, we are on track and we continue to do everything that we can in terms of closing down the CCG and ready to migrate from the 1st of July. So that is a risk that is being managed very well at the moment. I think we may have already covered the COVID-19 level 3 from a previous level 4, so that is where it is at the moment. But as we move forward into ICB, the current, obviously, Governing Body Assurance Framework will convert into an ICB risk register, and then each of the 3 alliances will continue to manage their risk register as well. So that's something that we're working through and will be managed by what we call a DATEX electronic risk register system going forward. So I'll leave it there because I think Ed has got his hand up.
Ed.
It was just on the monkeypox risk that Lisa had raised. I don't know whether it's probably not the moment now to add it on, but
Yeah.
it may well need to do so quite quickly.
Yeah, I was just thinking about that actually. Yeah.
I think we should, because obviously the GBAF is going to migrate and transfer, isn't it? So I think it's important that we do capture it now so that we're ready to hand it over, so to speak, at the appropriate time. And then the only other thing, Chair, that I wanted to mention was appended to the risk register is obviously the detailed risks pertaining to each directorate that we continue to keep a watchful eye on through our monthly risk forum. Thank you.
Thank you. Any questions for Amanda? Okay. Still with you, Amanda, the declarations of interest.
Thank you very much, Chair. So this is our usual report that I bring to the governing body twice a year. And as we can see, this is the most updated version that we have, where we have to declare any particular interests. And we also note where we do have current gaps as well. And I would just invite the governing body to offer any kind of thoughts on how we may need to or can improve this going forward. We do have an electronic solution through ESR that we're looking to implement, but I think it would be a polite reminder to anybody that hasn't declared to actually get their form completed and returned to me as soon as possible. Thank you.
Thank you. Item 16 then, the National Staff Survey results.
Thank you very much. So I may have recently updated through another forum, but I just wanted to bring it to part one today because it is actually a very positive survey that we received back in February. And this was as a result of our surveying our staff through the national process during October and November of last year. And as we can see in the report, the survey focused on the 7 key elements of our people promise, in addition to 2 previous themes that we have surveyed prior, such as staff engagement and morale. And as we can see, we had a response rate of 66%, which was okay. We could have actually done better, but, you know, it's better than, I suppose we have to be satisfied that 66 is actually not too bad. And on a positive as well, we actually, as you can see from the graph, we actually scored above average in all of the areas, which I think is superb. And as we can see in the graph, we can see that we actually scored very well indeed. We weren't quite at the top, but I think it's fair to say that we did score above average in each of those 9 areas, which is very positive. And as we can also see, our best scoring elements were around flexible working, working as a team, and the fact that the CCG is compassionate and inclusive. The report also articulates where we had our top 5 questions that received a higher than positive score compared to the national CCG average, and they are shown at the beginning of page 2. So again, some very good high percentages there. And then we can also see as a reverse where we actually need to improve further, and there were no surprises, I think it's fair to say, in regard of this. We know that we need to be better on our appraisals, and we have plans in place for this year to improve that. And we also know that we need to get better the appropriate digital kit for staff working both within the office and at home. So work continues with regards to that. And then I've included a regional comparator where we can see our CCGs and how we benchmark against all the others within the region. And I think that is a very positive graph because we can see in all areas bar 1, we actually scored the highest. So that is very good news indeed. And then as we move forward, clearly work continues through our staff engagement groups and organisational development groups to actually look at how we can get better at things like the personal development plans, the appraisal processes, making sure that we have good health and well-being and the like. So all of the actions that I have referred to in section 3.2 are well underway, and we will obviously report where we are at our next remuneration committee, and then this will move into the ICB post July. I will leave it there, Chair, but very happy to take any questions.
Thank you. Any questions? Okay, thank you very much, Amanda.
Thank you.
On then with you again to item 17, health and safety.
Thank you. So this is again a standard report that comes to governing body a couple of times a year, and as we can see, the last meeting met at the end of April, and in fact that was indeed the last health and safety committee of the CCG before we transition. But in terms of the key areas that we spoke about, it was really making sure that our officers were safe to welcome folk returning to work, and also just making sure that there was nothing untoward with our current sickness absences, which there weren't. And we were just then finally reviewing our annual plan, which will then transition into July. So a very standard but positive meeting. Thank you.
Thank you. Still haven't got Richard back yet. I must have frightened him off, mustn't I? Item 18 then, the minutes of the meetings. Jeff, you usually take us through these.
Thank you. Yes, we've got minutes from the various committees, audit, finance and remuneration. I think we've also got commissioning governance there too. I just asked the committee to endorse those minutes. I think the key issues in most of them have been covered on this governing body paper, particularly the staff survey. All the financial issues have been covered, and the audit and the accounts. Again, Jane has covered that. The audit is ongoing and the draft report's been checked, etc. So I think everything's in hand. So I'd ask the committee to endorse the minutes attached, please.
Thank you very much. Any questions for Jeff or anybody else for that matter? Okay, thank you. Item 19, Amanda, the new Suffolk and North East Essex ICB Constitution.
Thank you very much. So the updated constitution has been taken through the collaborative committee a couple of weeks ago, but it has to come here for endorsement and approval. But in terms of the background, work began last July when NHS England published a national constitution that all systems needed to work through accordingly. And since last summer, there has been many reiterations to that. We have continued to mature and update and get to a final state where we are happy with the constitution. The ICS board, through the engagement process that we went through, have supported. And I think it's fair to say our constitution, the majority of the content has been actually mandated to us. So we've had very little wriggle room for actually adapting and the like. But I think it's fair to say that we're now there with our final constitution, which the CCGs have to accept and endorse as we move into the transitioning period. So it's here today for us to approve. Thank you.
Thank you very much. I think approval has to be taken, really, doesn't it? Because there isn't a lot of choice at this point. And unless anybody's got any questions, any points of clarification that they want, then I propose that that be approved.
Thank you.
Thank you very much. Richard has not returned. Does anybody feel they need to say anything about item 3 of little 3 of main item 13, the strategy and transformation?
I think we take it as read, Chair.
I think we do that, yeah. Okay, thank you very much. Right, that brings us then to item 20. There are no further meetings planned for this board. And I would like to thank you all very warmly for the many years, in most cases, that you've given to this board. We've had a successful time, I like to think, and we've had a good time as well. I would particularly like to thank Ed, who's been with the CCG from its inception to its demise. Took us all through the rather dreadful authorization process, which I'm sure you remember with some. I'm sure that's imprinted in your memory, Ed, and has led us, first of all, in the West for the first 5 years, as captain of the ship, and then as harbour master as he went to take over the wider reins. We really have blossomed under him, and I'm most grateful. And I wish you and the future organisation well. I think there are no questions from members of the public. And there